this issue that's been pretty much trending. We've been talking about it, but not surprising that the Pharmaceutical Society of Ghana actually issued an alert sometime last year. Did we really pay attention to that? There's a growing trend of tramadol abuse among Ghanaian youth in some parts of the country, and there's been some surveys that have been carried out which shows that the drug is used among market women, drivers use it, and in some cases students, so young people also use it. The abuse of tramadol as a pain relief drug, according to medical experts, functions like heroin, and that scares me really. It can cause psychotic problems as well as damage vital organs in the human body. But those who use it, do they really know? Even if they do they care? Is it getting better in terms of the advocacy, or the situation is getting worse? The Pharmaceutical Society of Ghana, well represented on the show this morning, Reverend Dennis Sena Awiti is here. He's the Executive Secretary, and I've also got the Deputy Executive Secretary, who is in charge of strategic plans. He's Strategic Plans Manager. Kwame Pepra Boite is also here. Good morning to you, gentlemen.
Good morning. Good morning, Mama V.
Dr. Eugene Dodoi will join us via Skype from Cape Coast. When we have him, we're going to put him through. But where do we even begin this conversation? I want to make reference to this alert that you issued, titled "The Proliferation of High-Dose Tramadol in the Country." This was published on myjoyonline.com on 20th September 2017. That's the publication on your screen back then in 2017 September. We're here in 2018, and the reports we're told is really getting worse. So at the time when you issued this alert, can you take us back to what you knew then?
Thank you, Mama V, and good morning to your cherished viewers across the globe. You know, as pharmacists, and as the professional body of pharmacists in Ghana, properly regulated, we have a very, very unique and united professional association. And thanks to social media and other media platforms, we are united in the things we do and provide information and receive information from our members across the length and breadth of the country, and even those in the diaspora. So when our members started getting various reports and people walking to community pharmacists demanding for tramadol, we started putting it on our various platforms for people to be informed and aware of this sudden increase in demand. And the reports kept coming onto our various platforms. Then others started bringing to the fore situations where people will even come with a leaflet of a used product or the package aluminium foil or of a used pack, okay? And who will be? You know, do you have this?
But that's a prescription drug,
yes,
correct?
So, and you look on the product pack, and you see 200 milligram tramadol, 250 milligram. These are not registered in the country. And if anybody knew at first hand the dangers of using that higher dose, it's pharmacists. This is what we learned in school. This is what we practice. And so we became worried. And so the governing board of the Pharmaceutical Society of Ghana, having received all these various reports and the fact that there were anecdotal evidence from people when they are interviewed in terms of what is being done and it's being sold here and there. So we had to alert our members. So, of course, you know, if there is increased awareness, then the reporting increases, and then you get to know what is really going on. And so we took it upon ourselves that our members should do the grassroots education. When the person comes to you to demand that, you sit the person down and then you try to educate the person on the dangers of using not only tramadol, but medicines that have not been prescribed for you.
Okay. I want to come to you, Kwame. This clearly has not worked, your strategy, the initial one, after the press, the alerts that you issued, because we're here in 2018 in April, and the situation has gotten worse, correct?
Yes. Yeah, correct. All right. I think that we issued the statement out there to inform people and then to start working towards getting a comprehensive national strategy to deal with the problem. So it's not only tramadol, it's opioid in general. So initial idea, as commissioned by the president and the governing board, was for us to look at the tramadol issue. But now a research team has been commissioned to look at the use of opioids in general, because in addition to the tramadol, other drugs were being used which contain opioids as well, especially benzyl with codeine. So what the president did was that he has commissioned the research team, and we are using one region as a pilot to really understand the situation on the ground and to be able to, model our interventions after that.
So which region is this?
All right, so we are using the Brahafo region as the region there we are doing the initial research.
Why BA?
BA because initially the idea was these drugs were coming from other countries, especially the high-dose tramadol. They were coming from countries out closer to Ghana, and BA is one of the towns that is very close to Ivory Coast. So it's easier for people to smuggle those goods in. So we decided to just select Brahafo as the pilot region, but we hope to use that information from Brahafo to be able to actually model our intervention. We have a lot of interventions that we have decided to actually do going forward. So the BA research is going to inform us as to the way we want to go. Because in as much as we understand that now, as a result of our statement, there's been public outcry of the situation, we still believe that we need to work towards dealing with the situation. I think one of the things that has not really worked well is regulation and ensuring that we do what is right when it comes to the use of these drugs. But yesterday I was having an interaction with the acting deputy registrar of the Pharmacy Council, and they are sending a strong signal to people who are, especially licensed chemical sellers, who are not even supposed to stock these medicines, and then wholesalers who sell these medicines to these people. And so that is where we are picking it from. So we want to ensure that we reduce access to the medicines, and then we want to ensure that we understand where we can put the interventions when it comes to the targets that we have.
But Reverend, those who use it would look for it irrespective of if you don't stock it in the pharmacies. After all, how many of them actually even walk to the pharmacies to get it? I hear you can easily get it on the market. People are buying it out there in the open. What is your role as pharmaceutical society when we talk about drug abuse and in this situation, the use of tramadol? What's your role exactly?
Mama V, you see, for us, if you even look at our numbers in terms of pharmacists, the WHO standard is one pharmacist to a population of 2,000. But looking at our numbers now, it's about one pharmacist to about 15,000 population. So the numbers are limited. Education is the key, and we can't be everywhere. So we will want to use platforms, the media platforms, the radios, the TVs, organize outreaches to churches, to mosques, to schools. And so these are some of the interventions that Kwame was talking about, the fact that we have a lot of interventions planned. But you know, as Pharmaceutical Society of Ghana, we thrive on dues of members, and we cannot, use dues to do this thing. So we are looking for resources. We'll find it, and then we'll use it.
So ideally, not to cut you, but ideally, when a patient comes to you with the prescription, how many minutes should I spend with you? What kind of things should I ask you?
Oh, it depends on when you come with a prescription. I have to vet whether even the prescription is valid. And there are features regulated by legislation and policy, which indicates what a valid prescription is. So the pharmacist will have to vet that prescription to make sure it is a valid prescription. When that is done, he then goes to check on the appropriate, whether the prescription itself, having satisfied himself that the prescription is a valid prescription, you now have to go through to see one, whether there are whether even the dosage is properly done in terms of whether it's a child, it's a male, female. I mean, prescriptions are individualized. We don't generalize them. So you vet the prescription to make sure it is for the particular patient, because and male or female or whatever. So you do that and you make sure that prescription is supposed to be given to that person. And then when that is done, after you satisfy yourself, the medicine, we have SOPs.
What's that?
Standard operating procedures in dispensing of prescription. So, because if you make an error in filling the prescription, then you still make that error will continue, or will probably continue if you are the same person giving out the medications to the patient. So what we do is that whoever attends to the prescription is not the one who dispenses the prescription, so that it is vetted by a second person, goes through before.
This is supposed to be the standard.
Yes, that's what I'm saying. This is the standard operating procedures we have.
I have never witnessed that. So no, as you were saying, I was just trying to imagine.
No, in the hospitals,
there's a second person to
vet. In the hospitals, it is done. In most community pharmacies that have enough personnel, that's why you shouldn't have one pharmacist.
So the fact so the reason you'd see two people in the shop is because one person reads the thing out and the other person is supposed to fetch the drugs to be sure that
fill the prescription.
Oh, okay.
So the person filling the prescription should not be the person dispensing it.
Okay.
Because if an error is made, then that error will continue.
You wanted to add?
Yes, I wanted to add that, yes, this is what is supposed to be done. And then the prescription that you give, you are supposed to keep the prescription. It's by law mandatory for you to keep the prescription in the facility. So if now the pharmacy council comes out there and then you have received tramadol, you have dispensed, and you don't have evidence of who you have given the medicines to, then the law must be applied. And I'm saying this not for anybody. It has to be applied even to pharmacists.
So we have a law regulating this?
Yes, we have a law that regulates the dispensing of these medicines. That when I have dispensed the drug to a patient, I need to keep the prescription within the facility. And we want to tackle this issue holistically. That is why we don't want to even limit it to just the education. That the law must also work in the pharmacies, so that when I've come and I've been given the medicines, the prescription is kept. So when we look at what you have within your, what medicines you have received, for example, you ordered for Tramadol from, say, company A, and then you took the stock in, and now you have used all the Tramadol within your facility, you should be able to point to the regulator that these are the people who have given the medicines to, these are the prescriptions that are indicating that the medicines have been used.
See, there are times where, when the prescriptions come to the pharmacy, for purposes of getting refunds, for the purpose of submission to the National Health Insurance Scheme, for the purposes of the fact that it's one prescription, you got one drug on it, you didn't get other, the patient will need, practically, have to take the prescription away. So what will happen is that prescription will have to, records will have to be made of what has been dispensed, especially controlled drugs and prescription medicines. It's important, so that, I mean, especially for the opioids and those other controlled drugs, narcotic drugs, and you have to, because...
So who's the regulator here?
Oh, you know, the medicines production, manufacture, distribution, it's by the Food and Drugs Authority. The practice of retailing medicines direct to patient is by the Pharmacy Council.
Okay. All right, let's bring into this conversation Dr. Eugene Dodoi, who is a psychiatrist. He's been kind enough to join us via Skype from his base in Cape Coast. Good morning to you, Dr. Dodoi. Thank you so much for your time. If you can hear me?
Sure, I can.
Okay, all right. I know this is one of your passions, really. You do a lot of work in this area. So let's start off with you telling us what your discoveries have been in these past weeks, months. The conversation about the use of tramadol has very much been in the limelight.
Yeah, thank you for the opportunity. The challenge had been this Tramadol is not a new thing. We've had opiate addiction in Ghana since the 1970s, where heroin was somehow introduced into the markets. And we've had abuse of drugs, usually the benzodiazepines, the opiates, all this while. The challenge we have had is, as the pharmacists are saying in the studio, we are not able to control the supply chain, and therefore drugs get into hands of people that they shouldn't be. One thing that how to manage this addiction problem, there are mainly two prongs to it. We have the supply reduction and the demand reduction. So the supply reduction is what we are talking about. That is trying to control the supply of the medications to people. And that is mainly the job of Food and Drug Authority, Narcotic Control Board. Other countries, they have drug enforcement agencies as well. So it's more or less trying to crack down the drug coming into the market. But it's been shown over the years that that has not been effective. And the world over, everybody is moving towards what we call demand reduction. That is, people who are using, let's help them to stop, because addiction is a disease of the brain. It's not even a mental problem. It's a disease of the brain, like a stroke or something like a seizure disorder. So this is something that, as a country, we need a coordinated and collaborated effort between Food and Drug Authority, Narcotic Control Board, the Mental Health Authority, the Pharmaceutical Council, Ghana AIDS Commission, to get people who are using these drugs to quit, to get people who have not started not to start at all, then to get those who have suffered complications from the addiction rehabilitated. So until we go by the two-pronged approach, just going by the supply reduction alone has not been shown to work all these years. And it's unfortunate we are still kind of going about trafficking and arresting, and I mean, that has not shown to work. Let's help people who are unfortunately addicted to it. Most people use this without knowing the effects, as they are saying. They have no idea.
Yeah.
Meanwhile,
but if they knew, would they even stop? If they knew, would they stop, do you think?
Well, I mean, it's like saying that if people know their blood pressure will go up, would they leave? I mean, of course, when people are not aware they are sick, and you make them aware they are sick, and you show them how to manage it, most people would accept the treatment and live by the treatment. So there's a way to manage it. It's just like any chronic illness, like hypertension or diabetes.
You know, the reason I say that is because we've heard that young people, students, people who are in school, and because of what is able to make them do, even when you tell them the side effects, they don't want to listen.
Yes, excellent. So these are all kind of like part of the problem, because I mean, like they said, they are piloting in Babuna Hafo, and again, it's the lack of coordinated efforts as a country. We have Narcotic Control Board officers and Mental Health Authority, including myself, have been trained by ECOWAS, by the African Union Commission, to have a national observatory of drug abuse, not only about tramadol or opiates alone, but all drugs being abused in Ghana, which includes alcohol. So we need to have this national observatory down, and we know what is the problem. Because as of now, we've not defined the problem. Most people are using the tramadol because of its pain effect. I mean, it can alleviate pain. Unfortunately, all the uses of opiates for even pain alleviation and sleep, if you take it for some time, it stops working. So that is why they are taking the higher doses, and eventually it will damage organs in their bodies and it will kill them. So there's one other side effect that it tends to delay orgasm. So the young people who already have the strength, I mean, can therefore have sex for a longer period, and therefore they think it is helping them. But in the long run, they will damage their body, they will damage their brains. They can get hooked into this drug, and unfortunately, these young people will not be able to even use their skills, their strength to their country's, I mean, productivity. So the huge challenge now we have that we should make a diagnosis. Who is using the product? Where are they? What is the reason? We need a national observatory to find out where the challenge is, and then to tackle it at a national level. At the level of the individual, that is when they come to the doctors, to the psychologists, when they are already addicted or when they are at risk of addiction. Then they are helped to quit. But the bigger problem is that let's know which Ghanaians and where are they living who are using this drug. It's actually worse than this. In Ankara last year, I saw 2 people who are injecting street drugs. And this is a remedy for disaster. It easily causes overdose and death. So they moved away from injecting the lesser drugs like pethidine, morphine, and tramadol. Now they are injecting heroin. And that is the danger. So once it is now in the ghettos that they are using drugs, it will spread all over the country. And I saw this in Cape Coast. So it's a big challenge now.
Yeah, just hang in there for me. Dr. Eugene Dodo is a psychiatrist, and he's joining us via Skype from Cape Coast. But I've also got in the studio Reverend and Kwame as well from the Pharmaceutical Society of Ghana. You've been listening to him, and somebody sent me a message in reaction to what you're doing in the Bravo region. And this person says, in BA, another distribution line has been those aliens who move about pretending to be buying waste products. This coordinated effort that Dr. Dodo was alluding to, on that basis, I want to find out who are you collaborating with in this work that you're doing.
All right, thank you very much. I'm very happy that Doctor has mentioned, and this is what the Pharmaceutical Society of Ghana is doing. We are working together with the FDA and the NACOB. But what we wanted to do before we share these findings is to understand the problem very well, as he has mentioned. Because one, we want to find out who are using it, why are they using it. In as much as we talk about this in the media, and then we know that these are the possible reasons that people use it, we want to have a proper research to understand the problem. That how many people are using it. If it's the youth, what are the targets? If it's mothers and fathers, why are they using it? So that in our discussions, we can actually have the right intervention. Those who cannot stop if I'm using it and I'm addicted, because we are assessing all those things so that we can share and then model our interventions after the findings of this. And that is what we intend to do. And we are collaborating with the FDA and the NACO, but I think we need to reach out also to the psychiatrists so that together we can have a very comprehensive national strategy. But it is in our proposal that we are sending out for funding. And once we get the funding, these are the people who are going to be in there for us to work together and deal with the problem. Because it could be anybody.
I've listened to you say that tramadol is not the only drug that we should be afraid of. There are others that have come up that you've observed.
No, Mama, I mean, we're just discussing before we came to the studio. We want to keep the focus on tramadol. You know, like the others, which are not necessarily opioids. I've been talking to the Director General of the Education Service, Professor Kwesi Amankwa. So it's we anecdotally we have identified a sect of the public who is doing so. It's that can be dealt with at that level. So I've been talking to Professor Wissam Ankwa of the
But you
Education Service.
think that, you know, dealing with the situation that way, because for a very long time, Tramadol, people had been using Tramadol, except that it wasn't out there. We're not talking about it the way we are talking about it now. But look at how far it has brought us.
You see, doctor alluded to that fact also, because the reporting of the problem can also be a problem as well, because we have read and we have seen in certain places where actually the media, some write-up in the papers, that they are actually telling people how to do this. So perhaps somebody is already using the medicines and is even using it the wrong way to get the benefits that they want. And then he sees that, oh, this could be done better. And then the person gets into it. So communicating the problem is very key.
Conversations, I think, as
open,
well.
Open health communication, it's completely different, as Dr. mentioned.
So one critical issue. So why is Tramadol easily out there?
Okay, so that
if it's a prescribed drug and you can, why is it easily out there?
That was what I was going to talk about. You see, when doctor talked about the fact that we are concentrating more on the supply chain side, I mean, it's illegal. It's illegal for the high dose Tramadol to be in the system, even if it is in a legal facility. It is illegal. FDA has registered 50 milligram and 100 milligram. So if I come to a properly licensed pharmacy and you have 250 milligram, it shouldn't be there. You understand? And like doctor said, when you are using the opioids and the euphoric effect you get, the feeling of high feeling you get, as you use it, it diminishes. And so you are tempted to increase the dose. So you are looking for higher doses, you understand? And so for us, it is important that we cut off the supply, at the same time trying to work on the demand, the people demanding for it, and the services that we need to attend to those demanding for it. So I agree with Doctor. It's a multi-pronged approach that we need to use.
So do you know if you go to the pharmacies around, we would not find the unapproved dosage there?
I mean, I can't
if I walk
say
into
yes
a pharmacy,
or no.
would I find 50, 100,
you are not
or I would find 250?
Mamavi, you are not supposed to find it. So once it's not been registered, you are not supposed to find it. But of course, FDA had shown to us that they visited certain facilities, one like over-the-counter medicine sellers, who were not supposed to be in stock even the legally required doses in Ghana at all. They found it, and they went beyond finding that to finding the one that were not supposed, the higher doses that are not supposed to be in the country at all. So I won't stick my neck out and say that you'll not find it there, but they are not supposed to have it. So if they are not supposed to have it, and we know they are having it, we should work on that as well. Whilst agreeing with Dr. Dodoe that we should look at the demand side and attend to patients, people who are demanding.
One quick one before I bring in Dr. Dodoe, in terms of those who are addicted, is there an alternative? And if you have a child or somebody in your life that you've realized is taking this, how do you begin to let them go of it if there's any help that in that direction? But if you don't have a prescription, because we talked about if you have the prescription, you talked about some standards that it goes through. If you walk into the shop with no prescription, what happens?
With no prescription, you shouldn't even receive it. Without a prescription, you shouldn't get that medicine. But the issue is that, you see, if you understand how the pharmaceutical sector works, somebody can have a pharmacy as a business and not have a pharmacist or healthcare professional there. So if we continue to see medicines as ordinary items of commerce, then that is where the problem is. Because the person who has been legally more or less licensed as a businessman to have the pharmacy is required by the same law to have a pharmacist on the premise. However, there is no pharmacist and the business is operating. So whoever is there, anybody there who doesn't know what a prescription medicine is, what is supposed to be given out without prescription or not, and somebody comes and asks for Tramadol, the person goes to take it. But people will say, oh, I went to the pharmacy, I got it. But if you understand that there are countries
I know somebody who went complaining of headache and he was given Tramadol.
Yes.
Painkiller.
Which pharmacist worth his salt will do that?
So what should we do? Should we begin naming and shaming? I don't know. What's the strategy?
See, we have said, when you go into the pharmacy, ask for the pharmacist. If there's no pharmacist, walk out. Go to the next one. Ask for the pharmacist.
But how do you know if somebody is a pharmacist or not?
All right.
I mean, ask for the pharmacist. When somebody comes and impersonates, I mean, you can't. When you ask for the pharmacist, the person says he's a pharmacist. Query, oh, are you a pharmacist? What's your registration number? What? I mean, you should be able, we've asked our members to wear coats with name tags, I mean, identifying them as pharmacists.
Okay.
I mean, these are things we are doing. It's done elsewhere. We've all lived outside the country. We know how professionally environments are run. And we are asking our members to do same. But I'm telling you that there are a lot of pharmacies, community pharmacies, that are not owned by pharmacists. And sometimes by the end of the year, the person has a beef with his or her pharmacist. And so from January to March, when there's more like, there's more or less a lax or relaxation the regulatory issues, because you are giving between January and March to freelancers. And there's no pharmacists at the facility.
Yeah. All right. Dr. Dodoy, so let's talk about addiction now. I mean, is there a certain strategy? Is there a form? How do you get people who are hooked on tramadol off?
Get to that. I mean, this is what we keep saying. The supply reduction approach has not worked. Let me give you a bit of history. In the 1930s, USA banned alcohol because they saw the dangers of alcohol on their people. What happened was that there was actually increased alcohol use through the black markets. Ghana does not grow cocaine or opium, which is used for the opiates, or heroin and stuff like that. They come from the Middle East, Afghanistan, Thailand area, and cocaine comes from Latin America. Yet they are easily available all over the country. So for us to think that if we limit it to prescribing or to pharmacy and all that, that has not shown to work over the years. When people want the drug, and people, like he said earlier, because people are demanding for higher doses, the higher doses have come on our markets because they have seen there's a demand for that drug here. So if we don't look at the demand side, the effort we do in, supply reduction is only showmanship. We can just come to the media, yes, we have seized a truckload of tramadol, we've seized a truckload of opium, yes, but if there's a market, it will still find its way into our country. So the individual who has addiction, it's about time as a nation we realize that addiction is a disease. So to have even a law that will punish somebody for using one roll of marijuana or cocaine, one joint or something, is actually shameful, because you see, nobody punishes anyone for having a stroke. So that if I have a disease called addiction and by that I'm using a drug, you send me to court so that I become a criminal, I become an ex-convict for the rest of my life. This makes no sense. People who are sick, people who have addiction need treatment. And it is up to us to offer that treatment. The treatment, we have forms of it. We have what we call the brief intervention, where every health worker, if they see that you are starting a drug of abuse, we tell you the side effect, we tell you the complication that you can suffer. That can help some people. But for some people, for others who meet at least 2 of the 11 criteria we use to diagnose addiction, they unfortunately will need help from a psychologist, from a therapist, from a psychiatrist, from a medical, but they will need help. They will have to go through rehabilitation. And that rehabilitation can either be in outpatient basis or be in a residential facility. The challenge is that it's very expensive. And as at now, the only government-owned rehabs are in the mental hospitals, Ankafo and Pantan, which is unfortunate because addiction is not necessarily a mental problem. They come only because they may suffer some mental health complications. And that is when we see them. So we should have a stand-alone rehabilitation centers. And there are a few of them even though they are all faith-based. I mean, we look at the House of St. Francis, Ignace Shaman. It's purely standalone rehabilitation. The Passion Rehab by Action Chapel. It's also a purely standalone rehabilitation center where people can go and seek help. But I mean, if they see any psychologist, if they see any psychiatrist, we'll be able to point them to where they need, where they can get help. Currently, with the Mental Health Act 846 passed, we have mental health nurses who are in the communities. They are community mental health nurses, and they can also help and guide you to where you can get help based on how severe your condition is. There are people who, after all the treatments, may have suffered some complications, like a young person who couldn't stop and has lost or didn't get skills. We need to retrain these people to get skills and to be able to work and to be able to contribute their part to society. But I think the bigger level is not looking at the supply side, but let's look at our people who are demanding this, and let's stop them from requiring the opiates. If we're able to stop them from demanding, the market will diminish. Unfortunately, as a country where we are in West Africa, we are a major transit hub for drugs of abuse. So we get people using our ports to traffic cocaine, heroin, amphetamines, and all that. Unfortunately, we've even had a certain parliamentarian who has been arrested for drug trafficking. So it is not, young people's problem per se. The older people benefit from the young being sick. Addiction is mainly, the disease addiction is mainly a problem for young people. People start in their teenage to use drugs, and then it's been shown that 1 in every 10 adults will have the disease addiction. But if people start using drugs as early as 15 years, it's been shown that 1 in 4 of them will get addiction. So it is really a scary thing that we have our youth being hooked on drugs.
Definitely.
So there must be intensification of education. We need a head-on approach to solve this problem, and not just look at the supply side. I'm afraid that has not worked for all these years.
Okay, but I wonder as pharmaceutical society, I wonder what more they could do beyond what they plan to do. We'll come to that, but I'm activating the phone lines now. You can give us a call, 030221169102, 030221169102. We've got Asari Miracle from Koforidua, who's got a personal story to share. But let me read this. This person says, and it's a text as well. You can send me WhatsApp text, and then you can join us via phone if you can. It's alarming how young guys use Tramadol, especially in the Karaga district of the northern region of Ghana. I wish that community was part of the pilot survey. You would have gotten a mind-boggling results there. That's a text message that's just come through. But Asari Miracle is in Koforidua, divorced his wife because she was addicted to opiates. She was an addict for 4 years. Asari Miracle is joining us via phone now. Hello? Hello?
Hello.
Hi, Ms. Asari, good morning to you. Thank you so much for your time.
Yeah, good morning.
This is your personal story?
Yeah, I'm kind of passionate about it. It's not been easy at all.
So you're still living with it?
She is still living with it, but currently I would say, in my own estimation, maybe I have recovered about 60%. It's been an emotional trauma. Whenever I hear the word opioid, I feel like just burying myself somewhere. I have not tried it before. Unfortunately, my wife got herself engaged with opioid.
Do you know how she got involved?
Well, that is why I called in. What I think is happening is that we are not trying to go to the root cause. You see, talking of access, where people get access is, directly linked with the health sector. My wife is a nurse. In the interview we had with her, in fact, I've taken her to about 3-4 different kinds of all the good rehabs you can think of. met all the psychiatrists, maybe with the exception of Dr. Eugene. She was into it. We interviewed her, and she told us that she was introduced by colleagues, okay, doctors. So that would mean that there's something going on at the hospital that we need to look at. I mean, I'm talking of regulation at the hospital, because apart from the pharmacy, we shouldn't put all the burden on the pharmacy. In fact, the places that she gets it, when we interview her, one is the open market, mainly Okainshi to be precise, and also at the hospital where surgeries are done, where they have access to those opioids like pethidine and the rest.
Okay.
Okay. Apart from that, when, it's only become obvious, it becomes a problem when the person becomes an addict, because when she started using over a period of time, nobody knew about it. She was basically dependent. Then eventually she got to the abusive state where she became an addict to it. That is when it became obvious. And that is when it becomes a challenge. So what Dr. Eugene is saying is one very important thing. But then it also comes to a certain, challenge, cost.
Do we know what she was using it to cure?
Well, for her, initially it was nothing about cure.
Okay.
She, at the consultant at the hospital, they used it for just the euphoria bit, just to be hyper, they go on night duties and stuff like that. And she would tell you that a lot of the doctors and the nurses are opioid abusers. This is what she told us. You understand? So it's like a cartel, like it's within those perimeters where somebody would deliberately introduce you to be in the same circles with you.
Yeah, I get you. Can you just hold on a bit? Don't hang up yet. I want to bring in Dr. Dodoy. He's been listening to what you've been saying. So maybe a reaction from you, Dr. Dodoy.
Yeah, it's quite sad, and I think he's just, hit the nail right on the head about the fact that health workers are at greatest risk because we have access. But what we fail to realize is that addiction, as I said, is a disease. You see, it's not everybody who drinks alcohol who becomes alcoholic. It's not every health worker who injects pethidine or tramadol that gets addicted. There are people who have defects in their brain that when they get introduced to a drug of abuse, they can't stop using. They are the ones we say they are sick. So unfortunately, he thinks that when it became a problem was when they also, at that time, we see it as a complication. She's gone through the whole, lot of the condition before, because before other people see that you have a problem, it's usually very late. So, we should, and the mental health authority has actually come up with a solution to help the health sector. We should have what they call employee assistance programs.
Is that effective? Is that effective? Is that on the ground? Is that real?
That has been shown to be effective outside Ghana. Okay, it's been shown to be effective in the West. We don't have to reinvent the wheel. Let's get people at our workplaces where start using drug abuse.
So that's something that doesn't exist. So that's something that doesn't exist yet, even though it's in our books. No, but is there a way that we can connect Asari Miracle to you, so you can have a chat and see how you can support in this area?
Sure. I'll be very grateful to help.
Okay.
I have been trained for this, so.
Asari Miracle, are you still on the phone line?
Goes right.
Okay, you're still there. Kindly leave your number with my producer. He will take it now, and then we'll call you back right after the program.
All right.
Okay. We're very grateful that you opened up to us to share this with us. Really, really grateful. Kwesi Ibrahim from Drobo, I apologize because you've been holding on for a while. Good morning to you.
Good morning.
Yes, sir. Please, let's hear you.
Okay, thank you very much. First and foremost, I'm a community psychiatrist, like Dr. Dodoy said.
Okay.
The drug people, our friends and our big brothers.
The pharmacists in the studio.
Yes,
okay.
Yes. I'm sorry for the way I address them. I'm very sorry. If they say they are using BA, that's very good because it's a big problem in BA. But I am at trying to ask them that if they are in BA, they should not limit themselves to Sunyai. And then also, they should be in touch with mental health, psychiatry. Because almost all the districts, we have community psychiatric nurses, like Dr. Dodoy said. And these community psychiatric nurses are directly in contact with these problems. These problems come to them. Me, here in Drobo, I've encountered like 6 of them. And all of them, they came in the form of the addiction and the withdrawal when they were not getting the drug. Because of one problem or the other, so they couldn't get access to the drug. So they went into addiction and they were admitted and we were called upon to sort of help. So if they can actually do a good research, I know there are so many ways they will get their research done, but they should try their best not to leave mental health or psychiatric care in the region.
Okay.
They should ensure they contact the DPNs through their coordinator in the region so that they can go to the district. You see,
okay.
that's where
All
they
right.
can actually get a good data.
Okay, Kwesi, they've been nodding, and fortunately they are the bosses as well, so they get the message right there. So thank you. You said secondly?
Like I have a little contribution again.
Okay, please make it real quick for us.
Okay. You see, we need to pay attention to addiction, like Dr. Dodoy said. We should not only concentrate on the supply chain. Addiction is a huge problem that is very costly. So we need to take care of it. Introduce addiction as a subject. Train addiction psychiatrists and addiction psychiatric nurses so that they can actually handle it, because it's an expensive thing. When people get into it, their relatives and the rest, they all lose their jobs and the rest.
Okay. Kwesi, we'll have to leave it here. We have to leave it here because of time. Thank you very much. Thank you very much for your contribution as well. And I appreciate the fact that we're getting people who are really involved in it, opening up and phoning in. Unfortunately, we can't take any more calls because of time, but I sure can read some messages. So this one says, Dr. Eugene Dodo is right on point on the use of Tramadol. It should be tackled from the people that are demanding for it. Adam Rufai in Tamale sending this text message. This one says, interesting submissions by the 2 gentlemen. It's really sad what it does to people who get hooked to it. They are like a living reference to the dangers of opioids. Educating and blocking supply channels have always failed. It's unfortunate, but I'll say the moral aspect of our educational system has, and that's where the text message ends. This one says the only way of using this Tramadol, it helps with the men to sex girls. So somebody saying for sexual satisfaction. I've got an interesting question to ask in wrapping this up. This Daniel in Tamale says, I've always told my colleagues that in the next 5 years, madmen will be more in Tamale because Tramadol use is very normal here. I could say 80% of the population in Tamale use the drug, which is very serious. Well, in the absence of any scientific survey, you can't say 80%. That's a huge figure. This one says it's shameful and embarrassing to the pharmaceutical department of Ghana, most especially Tamale, for the high increase in the intake of this deadly donor. Board of Pharmaceutical Department is concerned. So it looks like there's a particular, thing with Tamale, with this drug. This person says, my grandmother went to a licensed chemical shop to complain about her body pains. The seller gave her Tramadol 50 mg plus, is it pyroxicam 20 mg, and told her, the last word didn't come before in Mampong. But this is not supposed to happen. Yeah. Okay. And I have lots of messages, but unfortunately, I'm not sure we can read all of it. This one says, come to Tamale and you'll be shocked how young guys take pride taking this drug, especially the Tramadol. Luknas from Tamale sending this message. Let's see if I can read 2 more WhatsApp messages. Kwame Ampom from Jacobo says, I think the FDA should be more on educating the public on the adverse effects of the use of Tramadol. This will deter people from using the drug. Thank you, Kwame. This one says it's very pathetic as a nation, Ghanaian youth to get involved in all sorts of harmful drugs, which is killing the future of this great nation, Ghana. Bernard Nyame in Chofo Praso. And I've got to apologize because we've got a lot of your messages that unfortunately, I will not be able to read because of time. Dr. Dodoy, if you're still with us, just in wrapping up, because we have to wrap up now. The question I wanted to ask, a lot of people take it for sexual satisfaction. Is there an alternative?
Yeah, there is. In almost most medical conditions, we say that rule out a general condition before a mental health. But when it comes to sexual health, you rule out a mental condition before, any medical condition. Because sexual health, the first sex organ is your brain, indeed. So,
Hello?
educated on how to have
Hello, Dr.
to delay. Hello.
Yes. Kindly end it very quick for me. We have to go.
Sure. I'm saying that young people need to be educated on how to have good sex. You don't need medication to aid your sex. There is always a non-drug therapy to sexual dysfunction, and that is the best way, the best approach to have it.
Okay.
And we don't need the drugs for it.
Okay.
Thank you.
Thank you so much. I appreciate your time with us, Dr. Eugene Dodoy, live from Cape Coast. And you've heard a lot. We've heard a lot from you. You've gotten a lot of feedback. Just your final words, and then we quickly run.
Mama V, I think the issue about tramadol abuse is one that the whole nation needs to take seriously. Reading the text messages, the phone calls that came through, you realize that it is a problem. And the fact that for us, we are interested because we are supposed to be the custodians of medicines. We are saying if you have any condition in the community, ask for the pharmacist. Walk to the nearest pharmacy. Ask for the pharmacist, because not everybody that's in the facility, that's the pharmacist.
Okay.
Ask for the pharmacist.
All right.
When you are in doubt about the use of medicines and your condition, ask for the pharmacist.
Okay.
And ask the
Kwame,
pharmacist.
anything to add?
All right, I think that I would have said the same thing that he has said, but what I want to say, especially with Doctor's comment, is that we want to work together and deal with the problem, because it could be anybody. And we cannot rule out the fact that access to the medicine could make it much more worse. So we want to deal with it from the various sections.
Okay.
And we are going to adopt a multidisciplinary approach and work together with all the stakeholders to help us deal with this.
Very well.
We want to appeal that anybody with funding who want to support this, we will be very happy to discuss this with them.
Especially because the dues definitely not enough to do this. Thank you so much, gentlemen.
Thank you.
Thank you for being here.